So now we're going to switch gears a little bit and hear from a couple of clinics who participated. And again, we want to thank our pilot clinics. And it's really my pleasure to introduce our first speaker, Erin Connelly. So come on up, Erin, while I introduce you. I had the pleasure until last fall of working with Erin in an organization. Erin works for the Multnomah County Health Department, where she leads the quality improvement efforts. They've been working on patient experience for quite a while. And so Erin bravely offered to come up and share her story with us. So Erin.
So I'll stand behind here. It's the closest proximity to a mic. Can you all hear me? Okay. So yeah, thank you for the introduction. We definitely miss Susan where we're at, but it sounds like you're doing amazing things. So why do we measure patient experience of care? So the best reason is that patients with better care experiences have better outcomes. That to me, I mean, this slide pretty much could just have that up there and we'd be good to go. But it also helps us identify and target where we need to make improvements. And then, of course, probably the least important reason is that there's certain external incentives. The patient-centered primary care home program and also CCOs, they're starting to incentivize using certain patient experience surveys. So I guess this is kind of in order of best reason to least best reason to measure patient care experience, but they're all factors in why we chose to do it at Multnomah County. So we've actually been measuring patient experience for probably almost 3.5 years. We started in 2009, and we measure, we have our own internal survey that we do quarterly, and we do it for all of our clinics, our school-based centers, our dental, pretty much everything. And it has, there's 25 closed-ended questions, I guess you could say, and then 2 open-ended questions. And I have to say, even though the closed-ended questions are valuable, we get such rich data off of the open-ended questions that those are my personal favorite to look at, actually. But they were based on CAHPS questions. So the survey that we are trying to move towards, it won't be too much of a shift because the survey that we currently use already has things like access to appointments, basically what we just heard now, patient-centered team-based care, and then we have some demographics and health status questions as well. And that's what our reports look like. So quarterly, managers get these reports, and then they take it back to their clinics and share it with staff in all staff meetings and then in team meetings. And then the coolest part is that the staff makes sense of the data. You know, they look at it and say, you know, how have we improved or not improved from last time? What are some things we can focus on this particular quarter to look at? And I just wanted to give you an example of one of the things. So our mid-county clinic, they kept on hearing time and time again how the front desk was really congested and it was really a confusing place to be. You walk in, there's a million things going on. So if you look, I should gesture over here, can you hear me? So it was getting really packed around here, and so that, the staff actually came in, they looked at some possible things to improve, and they realized, for example, you know, the play area was over here, right by the door, and interpreters were waiting right over here. So there was this bush right up front. And so using patient satisfaction data saying, we have no idea where to go, we're not really sure where the line starts, we can't really see the front desk staff. So they made tons of improvements that have really changed just the feel when you walk in. It feels completely different to walk in. Things are much more organized, there's not so much congestion, and then there's little feet showing you where to go. So why we chose to participate in the CAHPS pilot, you know, like I said, we are getting more and more incentivized to use this survey, but for me and for you know my colleagues where I work, there really is such a value in using the same instrument. You can benchmark, you can see kind of where you are in relation to your peers. And then of course the learning collaborative. If you're all in the same boat, you can work together, and you know none of us are going through things that the rest of us haven't heard of. So really learning from your peers and trying to figure out, well, how can we make the patient experience better? What are you doing? What can we learn from you? And although our current survey had used a lot of the same questions, we hadn't used the actual CAPS survey itself. So we really wanted to pilot it and see, what's our response rate going to be? And we have a lot of our clients are English as a second language, so we have a lot of language needs. And so we were also curious to see how that would play out as well. So the findings, it was very valuable to see benchmarks. So that was great. And we just got our responses back last week, and so we're still kind of in the process of figuring out kind of where we go from there. And it really was a seamless experience for the clients. So what we do, or for the clinics. So what we do right now with our current internal survey is they're actually distributed in the clinic. And so this was our first experience with an external vendor, mailing the surveys to the clients directly. And so that was a good experiment for us. And then things to look into, like I mentioned, we definitely need to figure out how to address language needs. We noticed the clinics with the widest array of languages had probably the lower response rates. So that's one thing we definitely, because we want everybody's voice to be heard. And it was a lower response rate for us than what we were used to internally, but I think that's also balanced by the fact that, internally we do kind of a convenience sample. It's whoever comes in and we hand the survey to them. And this was a much more, rigorous research-based study. So I think that kind of balances out. So what next? We're trying to figure out, do we use only CAPS? Do we use CAPS also with our current survey? Kind of how to balance that. Also looking at the frequency of survey distribution. Do we want to do this quarterly, once a year, and then using our internal survey more often? And then this is what I'm really excited about too. We also want to supplement it with qualitative, what I call tracer or day in the life. Some of you might have heard of experience-based design, but this is where either staff or management or providers actually walk through an experience with the client and kind of in the moment see, oh wow, that front desk was very confusing, and kind of can experience that with the client as they go. So we'd like to do some survey-based patient experience, get some data from that, and then also supplement it with some qualitative data as well. And that's our story.
So Erin, can I ask you a couple of questions?
Of course.
Just in follow-up. So can you talk about, because you have been fielding similar survey for a while, can you comment on what you've done with it, what different levels? So is it just shared with providers? Is it shared with all staff? How have you used your survey up until now?
So to date, the survey is sent to managers, but then it really is distributed down to everyone pretty much in the clinic. And so they'll talk about it at all staff meetings. They'll also talk about it within team meetings. So team meetings would be the provider and then the staff involved in that team. And then we also talk about it at our QI meetings. And so it's really distributed pretty far and wide, so everybody's aware of what's going on, and also how the data is changing from quarter to quarter, which is important too.
Yeah. Questions for Erin? Yes.
I was curious, for the clinics that you have multi-languages, do you have language preferences where those surveys can be sent out in their language instead of just English?
Yeah, and for CAPS, that's what we're trying to figure out. The pilot was, correct me if I'm wrong, available in English, but then Spanish would be available if I think if the client called and asked, and so we knew that was not going to yield the kind of results we wanted to see. So yeah, but our internal surveys, we offer them in English, Spanish, Vietnamese, and Russian, and then we also have interpreters sit with clients and help fill it out. So in that sense, we're trying to get everybody's voice.
Other questions?
Hello, Erin. Do you have any methods to capture information from people who have low literacy levels?
Yeah, so that that is definitely an issue. I think in we'll have interpreters work with clients who have different language needs, but as far as literacy, I don't know that we've landed on something that helps. I mean, if the client asks for help going through it, I think then there's staff available to do that. But you're right, I don't think there's a solid way of figuring out, at least with the paper-based survey, if health literacy issues were an issue in that case. And that's why I think also supplementing with some qualitative data is really the way to go, because then you can get a spectrum of experience where health literacy or language issues might not get in the way.
Other questions? Sam, we have the microphone somewhere. Yeah, here you go.
Did I understand you to say that you mailed some of these surveys? And since you have so many Medicaid clients who possibly are homeless, how do you get it to them?
Exactly. So that was why we wanted to pilot. So our internal survey that we use, those are distributed at the time of service. So again, probably not rigorous from a research perspective, but that's the way we can get the clients, at the time of service. With the CAPS pilot that we participated in, that was mailed, and so we were anticipating, because of that very reason, somewhat smaller response rate. And so I think this was our first, effort. We just wanted to see how using the CAPS in this kind of external vendor method would go, and now we can take steps to address that.
It sounds like you're doing 100% surveying in the internal, or
no, it's not 100%. No.
So what percent were you surveying, both internal and on CAPS?
So internally, what we were trying to go for was at least, we figured that the end that would get us where we need to go is at least 20 per provider. And so, yeah, it's not a huge percentage at all.
So talking about the percentage, any comparison done in terms of the response rate and also the responses themselves between the internal and the external surveys?
Yes, that is an excellent question. And we only recently got our responses back, so we didn't yet have time to compare them directly. The cool thing is that we also had an internal survey issued pretty close to when the CAPS survey went out, which may or may not have affected that as well, in retrospect. But we'll have a pretty nice set of data from approximately the same time to really do a pretty good comparison and see how it stacks up. Thank you.
Any other questions? Yeah.
I'm just curious. You guys are up on the medical home model, correct?
Yes.
So I see this being such a great benefit to show teams. You mentioned that you're going to be showing staff. Could this also be maybe used as a way to encourage those teams who are now functioning together to be able to really see what their patients are saying, and then as they move forward in that team-based care model to be able to achieve those areas that might be lacking?
Absolutely, and I think that's primarily how we use it. I think when we get the survey responses back, we don't necessarily look at them and then implement a system-wide change right away. I think really it's a tool to start the conversation and get people talking about it. And even if they disagree, even if they say, I don't believe these results, it's at least getting people talking about it and thinking in terms of how can we make the patient experience better. And then part of that is having kind of small experiments at the team level or the clinic level so that they can really experiment and work with the PDSA system and quality improvement in their own team, in their own clinic, so they can really be in control of that. So that's how we've been using the results to date.
Great. Any other questions for Erin?
Yeah, very quickly. What was your response rate? How many did you send out and how many did you receive back?
I don't have the numbers with me right now, and I have them at the table, so I can,
Thanks.
I can get back with you on that.
And I think this is coming up as a theme I'm hearing around data sampling and validity. And stay tuned in our breakout session. You'll get to hear some of this, because this is always the first place people go, the data must be wrong, or the data's not enough sample. And I'm not saying those aren't valid concerns, but sometimes they can be the cover for, I don't really want to deal with this issue, because I'd rather say that it's really the data that's the problem, not us. So it's just a caution, but if you're interested, we'll be talking more about data, validity, and sampling and those kind of things throughout the morning. So thank you very much, Erin. This is great.